Welcome to the Deep Dive. We're the show that takes complex, highly technical source material and helps you build professional level mastery. Today we're tackling, well, a titan of abdominal anatomy, the liver. We're aiming for an intensive deep dive into its surgical blueprint. Our mission today, it's absolutely laser focused. This isn't about a simple overview. We want you to walk away with the kind of knowledge an elite professional uses every day. We're pulling directly from dense surgical anatomy texts, covering really everything, from how it develops in the fetus all the way to the tricky variations in its blood supply.
Yeah.
If you're someone who needs absolute precision, the kind of deep context that ensures surgical safety, well, this deep dive is definitely for you.
And that precision is non-negotiable, really. The liver isn't just big, it's incredibly intricate. You need to grasp it on multiple levels. We have to trace its origins from just a few cells, understand its microscopic working units, and this is critical. Internalize the sheer frequency of variations in its arteries and veins. They're notoriously variable. For tough procedures like a major resection or even a transplant, spotting those anatomical curveballs beforehand. That's what separates competence from true mastery.
Absolutely. And the source material we're digging into today is intensely practical, focused squarely on clinical and surgical relevance. So we promise we'll cover every concept mentioned, giving it the depth it needs to really sink in. Let's start right at the very beginning, shall we? Okay, let's unpack this blueprint. Starting right from how the liver gets built in the first place in utero. Because honestly, if you don't grasp that fetal plumbing system, the adult anatomy can seem, well, just impossibly tangled.
Exactly. We need to go right back to the foundation. The liver primordium, the very first hint of the liver, is visible incredibly early. We're talking stage 11 of development, which is just 29 or 30 days after fertilization. It starts as this simple outgrowth from the ventral side of the foregut endoderm.
Right, so it buds off the early gut tube. What triggers that specific outgrowth? What signals tell those cells, okay, you're becoming liver?
It's tightly controlled at the molecular level, as you'd expect. There are key signals involved right from the start. Things like fibroblast growth factor, or FGF, and also proteins in the forkhead box family, often called FOX proteins. These molecules basically tell that specific region of endoderm cells your fate is hepatic. They divert them from becoming, say, intestinal tissue.
Okay, so the signal is received, the path is set, then the cells start differentiating, right? Tell us about the cell types that emerge.
Yeah, the initial cells are what we call pluripotent hepatoblasts. Think of them as liver stem cells. As things progress, these hepatoblasts split into the two main functional cell types of the adult liver. You get the hepatocytes, which are the real metabolic workhorses doing most of the liver's jobs, and you get the cholangiocytes, which are the cells that line the bile ducts, the biliary system. These cells then start organizing themselves into structures called hepatic cords.
That's the cellular structure taking shape. But what about the circulation? The blood supply has to get established right alongside this, doesn't it?
Absolutely. They develop in tandem. The vascular framework actually arises from a different source, the septum transversum mesenchyme. This mesenchyme forms a kind of primitive network, the hepatic endothelial plexus. This shows up by stage 12, so around 30 to 32 days. Initially, this plexus gets blood from the vitelline veins, which drain the yolk sac. That starts around stage 13. But then, critically, it starts incorporating blood flow from the cranial or upper parts of both umbilical veins, which are bringing oxygenated blood from the placenta. And it's worth remembering, what else that septum transversum mesenchyme forms. It doesn't just contribute to the liver's structure. It also gives rise to the lower part of the diaphragm and the connective tissues that sort of anchor the liver. And that area where the developing liver capsule stays touching that mesenchyme, that contact point persists and eventually becomes the bare area of the adult liver. No peritoneum there.
Right, we'll definitely come back to the bare area. But focusing on the fetal circulation, here's where you see some really elegant design, isn't it? Why push all that precious, highly oxygenated blood from the placenta through a developing liver that isn't really doing much detoxification yet? Nature finds a shortcut.
It creates a shunt, exactly. By the second month of development, this structure called the ductus venosus forms. It's essentially a large, low-resistance channel, and it's absolutely vital. It allows that high oxygen blood coming in from the umbilical vein to largely bypass the developing network of liver sinusoids. Instead of filtering through the liver, most of that blood flows directly through the ductus venusus into the inferior vena cava and then straight to the right atrium of the heart.
So it gets priority delivery to the systemic circulation.
Precisely. It's essential for providing enough oxygen to the developing fetal brain and body. This bypass is non-negotiable for survival.
And for us, looking at the adult liver surgically, understanding this fetal setup is key because the remnants of this plumbing become really important landmarks, fixed surgical planes.
Exactly right. We need to know these adult remnants inside out. Those early vitelline veins, they are the origin of the entire portal system. They eventually merge and reorganize to form the superior mesenteric vein, the splenic vein, and crucially, the main portal vein itself.
Okay, and the umbilical vein.
After birth, when the placental circulation stops, the umbilical vein collapses and closes down. It persists as a fibrous cord called the ligamentum teres hepatis, or the round ligament.
And the ductus venosus, the big bypass.
That also closes off functionally shortly after birth. Its fibrous remnant is known as the ligamentum venosum. And these two ligaments, the teres and the venosum, they're not just historical curiosities. They are fixed, identifiable structures on and within the liver, providing critical orientation for understanding the internal segments.
Good point. And one final thing about the fetal liver's role, it's completely different from its adult function, isn't it?
Totally different. In utero, long before the bone marrow matures and takes over blood cell production, the liver has another primary job. It acts as the main center for hemopoiesis. That's the formation of all types of blood cells, red cells, white cells, platelets. It's the fetal blood factory.
Okay, let's transition now to the adult liver. Its structure, its position, how it's anchored. We know it's a large, dense organ, mostly tucked under the right rib cage, but often extending quite variably across the midline into the left upper quadrant. And it's generally wrapped in this thin, fibrous capsule, right? The capsule of glycin.
That's correct. Glycin's capsule covers most of the liver surface, and then that in turn is covered by the visceral peritoneum, the smooth lining of the abdominal cavity. But as we hinted earlier, there's a crucial exception, the bare area.
Right, where is that exactly and why is it bare?
The bare area is a significant patch on the posterior superior surface of the liver, specifically located to the right of the groove for the inferior vena cava, IVC. It's bare because it lacks that peritoneal covering. Here, glycin's capsule is directly fused to the fibrous tissue of the diaphragm.
So surgically, that means direct adherence.
Exactly. Accessing or mobilizing this part of the liver means you have to carefully dissect these direct fibrous attachments off the diaphragm, which can be quite vascular.
Okay. Now, surrounding the liver, we have these reflections of the peritoneum, often called ligaments. They act as anchors, don't they? Let's map those out, starting posteriorly on the right side.
Posteriorly, you have the reflections that form the right triangular ligament. Its posterior leaf is quite important. It reflects from the right lobe of the liver onto the diaphragm, but it also continues down, reflecting onto Gerota's fascia, which is the connective tissue layer covering the right kidney and adrenal gland.
And you mentioned this connection is key for mobilization.
Absolutely critical, particularly if you're planning a right hepatectomy or mobilizing the liver for transplantation. You need to take down these posterior attachments. The posterior leaf of the right triangular ligament and its connection to Gerota's fascia early in the mobilization. If you don't, and you try to rotate the liver forward, you put immense traction on the deep parenchyma near the IVC, risking tears and serious venous bleeding.
Makes sense. And extending forward from the triangular ligaments.
Extending anteriorly from the apex of the triangular ligaments, you have the left and right coronary ligaments. These attach to the superior surface of the liver more broadly to the underside of the diaphragm.
And where these coronary ligaments meet in the middle?
They fuse centrally to form the very prominent falciform ligament. This is the sickle-shaped fold that suspends the liver from the diaphragm, and importantly, the anterior abdominal wall running down towards the umbilicus.
So a complex system of anchors holding this heavy organ in place.
Yes. And within these ligaments, we find our fetal remnants again, acting as surface guides. The ligamentum teres hepatis, that obliterated umbilical vein, runs in the free inferior edge of the falciform ligament. It travels up from the umbilicus and inserts into the liver at the umbilical fissure on its inferior surface.
A vital landmark for finding the division between the left lateral and left medial sections.
Precisely. And equally important, posteriorly, is the ligamentum venosum, the remnant of the ductus venosus. This lies deeper, in a fissure on the posterior aspect of the liver, marking the path from the left portal vein up towards where the left hepatic vein joins the IVC.
And dividing this ligament is sometimes necessary.
Often, yes. For good visualization of the structures behind the liver, like the IVC, or for accessing the retrohepatic space during complex resections or transplantation, careful division of the ligamentum venosum opens up that plane, providing safer access.
This posterior region also involves the most, let's say, uniquely positioned segment, the caudate lobe, also known as segment 1.
Yes, segment 1 is anatomically distinct. It's situated dorsally, kind of wrapping around the IVC on its left side. Superiorly and anteriorly, it's separated from the overlying left lateral section, segments 2 and 3, by a couple of key structures. The gastrohepatic ligament, which is part of the lesser omentum, and again the fissure containing the ligamentum venosum.
And doesn't the caudate lobe have a sort of tail or projection that extends to the right?
It does indeed. As the caudate lobe extends towards the right, behind the porta hepatis, it forms the caudate process. This projection is surgically significant because it lies between the portal vein bifurcation anteriorly and the IVC posteriorly. It effectively separates those two major vessels at that level before it fuses with the posterior aspect of the right liver.
Okay. While we're back here near the IVC, there's another structure mentioned, the hepatocycal ligament. What is that?
The hepatocycal ligament is described as a fibrous band, present in most people. It essentially arises from the posterior aspect of the caudate lobe, loops around the anterior aspect of the IVC, and then joins the posterior surface of the right liver.
Is it vascular? Is it dangerous to divide?
Usually no. In the vast majority of patients, it's a thin, avascular fibrous band, and dividing it is straightforward and necessary to fully mobilize the IVC. However, and this is key, in a small minority of individuals, this ligament can actually contain a thin bridge of functional hepatic parenchyma, sometimes even small vessels. So you can't just bluntly dissect it. It requires careful inspection and controlled division, usually with cautery or ligation, just in case.
Good point. Always expect the unexpected. Let's move anteriorly now, towards the main gate, the hilum, or porta hepatis. The gallbladder sits right near there, doesn't it?
Yes, the gallbladder nestles in a shallow depression on the inferior surface of the liver, the cystic fossa, which is typically located just to the right of the main hilum.
And the key thing separating the gallbladder from the liver itself.
That's the cystic plate. It's not liver parenchyma. It's a distinct layer of dense connective tissue, sometimes containing small vessels and ducts, that forms the bed of the gallbladder fossa. This plate defines the correct surgical plane for cholecystectomy. The surgeon needs to stay just superficial to the cystic plate, dissecting the gallbladder off it.
And the danger zone is deviating from that plane, especially near the neck of the gallbladder, the infundibulum. Why is that area so critical?
Because the infundibulum lies directly over the major healer structures entering the liver. If a surgeon loses that avascular plane on the cystic plate and dissects too deep, especially with cautery, they risk catastrophic injury.
Catastrophic meaning?
Meaning thermal or direct injury to the common hepatic duct, the hepatic artery proper, or even the portal vein, which all lie just deep to the cystic plate in that region. It can lead to massive bleeding, bile duct strictures, or injuries requiring immediate complex repair. The margin for error there is incredibly small.
Understood. So the structures converging deep to that area form the porta hepatis. What exactly is contained within the porta?
The porta hepatis is the gateway. It contains the three major structures entering and leaving the liver. The main portal vein, bringing nutrient-rich blood from the gut, the hepatic artery proper, bringing oxygenated blood, and the common hepatic duct, carrying bile away from the liver, which becomes the common bile duct lower down.
Okay, we'll detail their arrangement later, but first, there's another surface landmark nearby that's mentioned as being really useful surgically. The sulcus of Rouvier. What is that?
Ah yes, Rouvier sulcus. It's a natural cleft or groove, usually about 2 to 3 centimeters long. It's not always present, but you find it in about 70 to 80% of livers. When present, it's located on the inferior surface of the right lobe, just to the right of the main hilum.
And its surgical importance, why is it so helpful?
It's incredibly useful because this sulcus, when identifiable, directly overlies the location where the right posterior portal pedicle, the bundle containing the portal vein branch, artery branch, and bile duct for segments 6 and 7 enters the liver parenchyma.
So it's like a surface map marker for the deep structures.
Exactly. It allows a surgeon planning a right posterior sectionectomy, removing segments 6 and 7, to potentially identify and control the inflow to just those segments before starting the parenchymal transection. It can significantly simplify inflow control for that specific resection.
That's a fantastic example of surface anatomy guiding deep dissection. Okay, one last key anatomical space before we move inward, the foramen of Winslow.
The foramen of Winslow, or the epicloic foramen, is the natural opening situated just behind the free edge of the hepatoduodenal ligament, which contains the porta hepatis structures. So it's posterolateral to the porta.
And its significance.
It's the gateway into the lesser sac, the smaller peritoneal cavity behind the stomach. Surgically, Its main importance is that it allows access for the Pringle maneuver.
Ah, the Pringle.
Yeah.
Explain that.
The Pringle maneuver involves passing fingers or an instrument through the foramen of Winslow behind the porta hepatis structures and then compressing those structures, hepatic artery, portal vein, bile duct, against the thumb anteriorly, or using a vascular clamp. This temporarily occludes nearly all blood flow into the liver. It's a crucial damage control technique in liver trauma to stop hemorrhage, and it's used intermittently during elective hepatectomy to reduce blood loss during the parenchymal transection phase.
You said nearly all inflow. What's the exception we need to remember?
The key exception, and this comes back to variant anatomy, is if the patient has an aberrant left hepatic artery. If the left hepatic artery arises abnormally, usually from the left gastric artery, it travels within the gastrohepatic ligament, not within the main porta hepatis bundle that gets clamped by the Pringle.
So clamping the porta won't stop bleeding from that source.
Correct. If there's ongoing arterial bleeding from the left side of the liver, despite a properly applied Pringle maneuver, you have to suspect an unclamped aberrant left hepatic artery. Mastery means knowing these exceptions.
All right, we've mapped the outside and the anchors. Now let's move to the internal organization. And you stressed earlier, we need to think functionally, not just based on old surface landmarks.
Absolutely. The old way of dividing the liver, maybe based purely on the falciform ligament or the umbilical fissure, is completely outdated for surgical planning. We have to use functional anatomy.
And the standard system for that is?
The universally adopted system is the Kuno classification. Its principles were formally standardized and nomenclature agreed upon by the International Hepatopancreatobiliary Association, summarized in the Brisbane 2000 terminology. This gives surgeons worldwide a common language to describe liver segments and resections precisely.
What's the fundamental organizing principle behind Kuno's system?
It's brilliant in its simplicity, really. It's based on the three major hepatic veins, the right, middle, and left. These veins run between the portal segments, collecting blood from adjacent segments. They lie within specific anatomical planes called portal scissurae, or fissures. These scissurae, marked by the hepatic veins, are the key because they represent relatively avascular planes. They are the safe highways for surgical division, as transecting along a major hepatic vein minimizes injury to the inflow pedicle supplying the remaining liver segments.
Okay, so the hepatic veins define the boundaries. How does this divide the liver?
The main division is created by the plane containing the middle hepatic vein. This plane, running within the middle hepatic vein scissura, divides the entire liver functionally into a right hemoliver and the left hemoliver. This plane corresponds roughly to Cantley's line, an imaginary line drawn on the surface from the IVC fossa superiorly down to the middle of the gallbladder fossa inferiorly.
So Cantley's line, marked internally by the middle hepatic vein, is the Great Divide. What about the other two hepatic veins?
The right hepatic vein scissura, containing the right hepatic vein, further divides the right hemoliver into an anterior section and a posterior section. Similarly, the left hepatic vein scissura, containing the left hepatic vein, divides the left hemoliver into a medial section and a lateral section.
Okay, so 3 veins create 4 sections. How do we get to the 8 segments?
The 8 portal segments of Kuno are defined by the inflow structures. Each segment receives its primary blood supply and drains its bile via an independent portal pedicle. This pedicle contains a tertiary branch of the portal vein, a corresponding branch of the hepatic artery, and a bile duct tributary, all bundled together in a Glisonian sheath.
Got it. So let's list the segments within their sections.
Right. The right liver has the anterior section containing segments 5 inferiorly and 8 superiorly, and it has the posterior section containing segment 6 inferiorly and 7 superiorly. The left liver has the medial section, which is just segment 4, and it has the lateral section containing segments 2 superiorly and 3 inferiorly.
And segment 1, the caudate lobe, we treat separately.
Yes, segment 1, caudate, is functionally distinct, as we'll discuss. So that gives us 8 segments in total.
Now, you mentioned earlier the potential confusion with the umbilical fissure. Let's clarify its relationship to these functional divisions again.
This is a really important point for avoiding surgical error. The umbilical fissure, the visible groove containing the ligamentum teres on the inferior surface, separates the anatomical left lobe into medial, segment 4, and lateral segments 23 parts. However, it is not a true portal scissura containing a major hepatic vein. The actual functional left portal scissura, the plane for dividing the left medial from the left lateral section safely, lies more posteriorly and contains the left hepatic vein. It often aligns more closely with the fissure for the ligamentum venosum posteriorly.
So cutting along the umbilical fissure isn't the functional boundary.
Correct. If you resect strictly along the umbilical fissure, you risk damaging the portal pedicles supplying segment 4, which lies medial to it. The true functional plane is defined by the left hepatic veins course.
Okay, now let's revisit segment 1, the caudate lobe, functionally. Why is it unique?
Its uniqueness provides a kind of biological backup system. First, its blood supply is often dual. It tends to receive small arterial and portal branches from both the right and left main pedicles. This makes it relatively resistant to ischemia if one side's inflow is compromised.
And its drainage.
Even more distinct. Its venous drainage is completely separate from the 3 main hepatic veins. The caudate lobe drains directly into the adjacent inferior vena cava, IVC, via multiple small variable veins called the short hepatic veins.
Which has implications for diseases causing outflow obstruction.
Absolutely. In conditions like Budd-Chiari syndrome, where the main hepatic veins are thrombosed, the caudate lobe often hypertrophies because its direct IVC drainage remains patent, allowing it to compensate. And surgically, these short hepatic veins must be meticulously controlled when mobilizing the liver off the IVC.
Okay, we've gone from the whole organ down to the functional segments. Now let's zoom in further, right down to the microscopic level, the basic functional unit of the liver.
Right. Historically, there have been a couple of main ways to conceptualize this microscopic unit. The oldest model is the hexagonal liver lobule, first described way back in 1833 by Francis Kiernan. In this model, you imagine a hexagon. At the very center is a central vein, which is actually a terminal tributary of a hepatic vein, the outflow. At each of the 6 corners of the hexagon, you have a portal triad or portal tract, containing branches of the portal vein, hepatic artery, and bile duct, the inflow and bile outflow.
So centered on outflow with inflow at the periphery.
Exactly. Blood flows from the portal triads at the corners through the sinusoids between plates of hepatocytes towards the central vein.
But there's another model, perhaps more relevant clinically.
Yes, the liver acinus, proposed later by Aaron Rappaport. This model is often considered more physiologically relevant, especially for understanding pathology related to oxygen gradients. Rappaport essentially flipped the perspective. The center of the acinar unit is the portal triad, the inflow. The outflow structures, the terminal hepatic veins, settle veins in the older model, are located at the periphery of the acinus.
So, centered on inflow with outflow at the edges. Let's look inside this acinus. The main cell is the hepatocyte.
Yes, hepatocytes are the star players, making up about 80% of the liver's volume. They are polygonal cells, remarkably versatile. A key feature is their polarity. They have distinct functional surfaces. A basolateral surface facing the blood-filled sinusoids for uptake and secretion into blood, and an apical surface facing tiny bile channels, canaliculi, for bile secretion. They are arranged in plates, usually just 1 or 2 cells thick, radiating out from the portal triads in the acinar model. These plates are separated by specialized capillaries called sinusoids.
And these sinusoids are not typical capillaries, are they?
Not at all. They are wider and lined by very specialized sinusoidal endothelial cells. These cells are unique because their cytoplasm is full of large pores or fenestrations. And crucially, unlike most capillaries, liver sinusoids lack a continuous basement membrane underneath the endothelial cells.
What's the functional consequence of these fenestrations and the lack of a basement membrane?
It allows for incredibly efficient exchange. Plasma fluid and large molecules like albumin produced by hepatocytes or lipoproteins can pass freely from the sinusoidal blood through the fenestrations directly into the space surrounding the hepatocytes.
And that space has a name, right? The space of Dissy.
Exactly. The space of Dissy is this crucial microanatomical location, the parasinusoidal space between the sinusoidal endothelial cells and the basolateral surface of the hepatocytes. It's filled with extracellular matrix, but importantly, it's also home to another key cell type, the hepatic stellate cells, sometimes called Edo cells.
And these stellate cells are quiescent normally, but become activated in injury.
Precisely. In a healthy liver, Edo cells mainly store vitamin A. But when the liver is injured by viruses, alcohol, toxins, fat accumulation, these stellate cells undergo a dramatic transformation. They activate, proliferate, and become myofibroblast-like cells. And their main function then becomes producing massive amounts of extracellular matrix proteins, primarily collagen.
And that excessive collagen deposition is...
That is liver fibrosis. The progressive accumulation of scar tissue in the space of Dissy, driven by activated stellate cells, is the fundamental process underlying fibrosis and its end-stage cirrhosis.
Okay. Also within the sinusoids, we have the liver's resident immune cells.
Yes, lining the sinusoids are the Kupffer cells. These are specialized macrophages, part of the body's mononuclear phagocyte system. They act as sentinels, constantly sampling the portal blood flowing from the gut, the phagocytose bacteria, cellular debris, endotoxins, and also function as antigen-presenting cells, playing a key role in the liver immunity and tolerance.
Before we get to Rappaport zones, let's quickly trace the path of bile from the hepatocyte outwards. How does that microscopic drainage work?
It starts at the apical surface of the hepatocytes. They secrete bile into tiny intercellular channels called bile canaliculi, formed between adjacent hepatocytes. These canaliculi then drain into slightly larger channels near the portal triads called the canals of Herring. These are interesting because they are lined by both hepatocytes and cholangiocytes, representing a transitional zone. The canals of Herring then connect to the bile ductules within the portal triad, which are lined entirely by cholangiocytes. These ductules coalesce to form larger ducts, eventually leading to the terminal bile duct in the portal triad, which then joins others to form the segmental and eventually the main hepatic ducts.
Okay, a separate, intricate drainage system. Now, back to Rappaport's acinar model and the concept of three zones. Why divide the acinus this way?
Rappaport's genius was recognizing that hepatocytes within a single acinus experience different microenvironments based on their distance from the incoming blood supply in the portal triad. He defined three zones. Zone 1, periportal zone, includes the hepatocytes closest to the portal triad. These cells receive blood that is richest in oxygen and nutrients freshly absorbed from the gut via the portal vein. Zone 3, centrolobular or paravenular zone, contains the hepatocytes furthest from the portal triad, located right next to the terminal hepatic venule, the central vein of the classic lobule. These cells receive blood that is already percolated through zones 1 and 2, so it is the lowest concentration of oxygen and nutrients. Zone 2 is the intermediate region between zone 1 and zone 3.
So what's the big takeaway? Why does the zonal difference matter so much clinically?
It explains patterns of liver injury beautifully. Because zone 3 hepatocytes live in a relatively low oxygen environment normally, they are the most vulnerable to hypoxic or ischemic injury. For example, in situations of shock, severe heart failure, or other causes of poor liver perfusion, ischemic hepatitis, the damage pattern seen microscopically is typically centrolobular necrosis. The cells in zone 3 die first because they simply don't have enough oxygen to survive, while zone 1 cells might be perfectly fine.
Fascinating. It also explains differential toxicity, right? Some toxins preferentially damage zone 1, others zone 3.
Exactly. Zone 1 cells, being first in line, might be more susceptible to direct toxins absorbed from the gut. Zone 3 cells often have higher concentrations of certain metabolic enzymes, like cytochrome P450s, making them more vulnerable to toxins that require metabolic activation to become harmful. Acetaminophen, paracetamol overdose, is a classic example of zone 3 necrosis for this reason.
Okay, let's map out the major plumbing systems now, starting with the arteries. And we've already flagged this one as being notoriously variable.
That's the headline for hepatic arteries. Expect variation. Somewhere between 24% and 45% of individuals will have an arterial anatomy that deviates from the classic pattern. But you have to know the classic pattern first.
Right. Define the classic hepatic arterial anatomy for us. This is Hyatt type 1, found in roughly 55–76% of people.
Okay, classically, the story starts at the coeliac trunk, which arises from the aorta. The common hepatic artery branches off the coeliac trunk. It usually travels anterolaterally, often running along the superior border of the pancreas. The key branching point is when it gives off the gastroduodenal artery, GDA, which typically heads downwards, caudally, behind the duodenum. Once the GDA is branched off, the continuing vessel is now officially termed the hepatic artery proper.
And where does the hepatic artery proper run as it approaches the liver? What's its position relative to the other main structures in the porta hepatis?
As the hepatic artery proper ascends toward the liver in the hepatoduodenal ligament, it assumes a consistent position medial to the common bile duct and anterior to the main portal vein. Think DAV. Duct is lateral, all right. Artery is middle medial, vein is posterior. Oh, and the right gastric artery usually branches off the hepatic artery proper somewhere along its course, but that's quite variable too.
Okay, so the hepatic artery proper reaches the hilum. How does it typically divide?
Near the liver hilum, the hepatic artery proper typically bifurcates into a left hepatic artery and a right hepatic artery.
Let's trace the right hepatic artery, RHA, first. What's its usual path?
The RHA usually, in about 90–95% of cases, courses posterior to the common hepatic duct. This is a critical relationship during gallbladder surgery. It then often passes through the triangle of Cowlett, bounded by the cystic duct, common hepatic duct, and inferior liver edge cystic artery, where it gives off the cystic artery to the gallbladder. After giving off the cystic artery, the RHA typically bifurcates again into anterior and posterior segmental branches supplying the right liver.
And that posterior branch, does that connect back to Rouvier's sulcus?
Yes, precisely. That right posterior sectoral artery is the branch that often enters the liver parenchyma within or very close to the sulcus of Rouvier, alongside the corresponding portal vein and bile duct branches for segments 6 and 7.
Got it. Now, the left hepatic artery, LHA.
The LHA continues more superiorly, cephalad, towards the base of the umbilical fissure. It very commonly gives off a significant branch called the middle hepatic artery, which is the primary arterial supply to segment 4, the left medial section. The LHA then continues on to supply segments 2 and 3, the left lateral section.
Okay, that's the classic 55-76%. Now for the challenge, variant hepatic arterial anatomy. This affects a large minority, 24-45%. First, let's clarify the terminology, accessory versus replaced.
This distinction is absolutely fundamental for surgical safety. An accessory artery means there's an additional source of arterial blood supply to a part of the liver, alongside the normal artery. If you ligate an accessory artery, the area usually still gets blood from the main vessel. It's a backup. A replaced artery, however, means the normal artery for that region is absent, and this variant vessel is the sole arterial supply. If you mistakenly ligate a replaced artery, the part of the liver it supplies will become ischemic and potentially necrotic. It's a critical vessel.
Understood. So let's review the most common types of variants. Based on the Hyatt classification system, which ones absolutely must be on a surgeon's radar?
Types 2 and 3 are the most frequent and surgically important variants. Hyatt type 2, seen in about 10–20% of people, is an aberrant left hepatic artery. This variant LHA doesn't come from the hepatic artery proper. Instead, it usually arises from the left gastric artery. Critically, it travels within the gastrohepatic ligament, ligamentum, to reach the left side of the liver hilum. It doesn't run in the main porta hepatis.
And that's why it bypasses the Pringle maneuver clamp.
Exactly.
Okay, what's Hyatt type 3?
Hyatt type 3, found in 10–15%, is an aberrant right hepatic artery. This is arguably the highest stakes common variant. Here, the RHA, or sometimes just the posterior sectoral branch, arises from the superior mesenteric artery, SMA. Its typical course is posterior to the head of the pancreas. Then it runs behind the main portal vein, ascending towards the right side of the hilum, often posterior to the bile duct as well.
Why is that course so high stakes?
Because it puts the main arterial supply to the right liver directly in the path of dissection during procedures like pancreaticoduodenectomy, Whipple procedure, where structures behind the pancreas and portal vein are mobilized and divided. Accidental ligation of a replaced RHA from the SMA during a Whipple is a devastating complication.
Wow. Okay. Are there other significant types? What about a replaced common hepatic artery?
Yes, that's Hyatt type 5. Less common, maybe 1.54%, but equally dangerous. In this scenario, the entire common hepatic artery is replaced, meaning it doesn't come from the celiac trunk at all. It arises entirely from the SMA. Again, it takes that dangerous posterior course behind the pancreas and portal vein before giving off the GDA and becoming the hepatic artery proper. Ligation would devascularize the entire liver, except potentially an aberrant LHA if present.
So the bottom line is, you absolutely need high-quality preoperative imaging, like CT angiography, to map the specific arterial anatomy before any major upper abdominal surgery involving the liver, pancreas, or bile ducts.
Non-negotiable. You
Yeah.
cannot assume textbook anatomy. You have to actively look for and identify these common variants. #tag B portal venous anatomy.
All right, let's move to the second major inflow vessel, the portal vein. This is the high-volume, low-pressure system carrying blood from the digestive tract.
Correct. The portal vein delivers about 75–80% of the total blood flow to the liver, rich in absorbed nutrients, but relatively lower in oxygen compared to the hepatic artery. The main portal vein, PV itself, is formed behind the neck of the pancreas. It's created by the confluence, the joining of the superior mesenteric vein, SMV, draining the small intestine and right colon, and the splenic vein draining the spleen, pancreas, and parts of the stomach.
And as it ascends in the porta hepatis towards the liver, its position relative to the artery and bile duct.
As we noted with the artery, the main PV consistently lies posterior to both the hepatic artery proper and the common bile duct within the hepatoduodenal ligament, DAV, duct anterior lateral, artery anterior medial, vein posterior.
How does the main portal vein typically branch at the liver hilum? Let's start with the left side.
The left portal vein, LPV, typically has a longer extrahepatic course than the right, often around 3 to 4 centimeters. It runs transversely towards the left under the caudate process. It then characteristically takes an anterior and inferior turn to enter the umbilical fissure. This accessible segment within the fissure is often called the pars umbilicalis. From this umbilical portion, branches arise to supply segments 2, 3, left lateral section, and segment 4, left medial section.
And accessing that umbilical portion via the ligamentum teres is key for some resections.
Yes, dissecting along the ligamentum teres hepatis leads you directly to this umbilical portion of the LPV, which is a critical step for gaining inflow control during a left lateral sectionectomy, removing segments 2 and 3.
Okay. What about the right portal vein, RPV?
The RPV usually has a much shorter extrahepatic course, often only 1 or 2 centimeters, sometimes even less. It can branch almost immediately after originating from the main PV. It typically bifurcates very quickly into an anterior right portal vein branch, supplying segments 5 and 8, and a posterior right portal vein branch, supplying segments 6 and 7.
Is portal vein anatomy as variable as the arterial anatomy?
Generally less so, but variations definitely occur and are surgically important. For instance, instead of a clean bifurcation, you might see a trifurcation of the main portal vein, where the main PV splits directly into the LPV, the right anterior branch, and the right posterior branch all at the same point. Other significant variations include the right anterior, or more commonly, the right posterior portal vein branch originating abnormally from the left portal vein, crossing behind the hilum. This needs to be identified preoperatively if planning a right-sided resection.
Now, let's talk about some smaller portal venous tributaries. These become particularly important in patients with portal hypertension, right?
Yes, when pressure in the portal system rises due to liver disease, like cirrhosis, blood tries to find alternative routes back to the systemic circulation, bypassing the high-resistance liver. These alternative routes are called portosystemic shunts, or collaterals, and many involve normal tributaries that become massively engorged. The most well-known is probably the left gastric coronary vein, which normally drains part of the stomach into the portal or splenic vein. In portal hypertension, flow can reverse, leading to large esophageal varices. But surgically, especially during biliary surgery, we need to be aware of the finer venous networks around the bile duct itself.
These are the veins of Saint and Petrin.
Exactly. There's a fine network of veins directly on the surface of the common bile ducts called the epicoledocal venous plexus of Saint. These drain into slightly larger veins running parallel to the bile duct, called the pericoledocal veins of Petrin.
Why is knowing these specific names important for a surgeon? What's the practical risk?
Because in a patient with portal hypertension, these normally tiny veins can become dilated, fragile, and engorged, forming a cavernoma around the bile duct. If a surgeon is dissecting the common bile duct in such a patient, for example, for bile duct exploration or reconstruction, and isn't aware of or doesn't anticipate these engorged veins, even careful dissection can lead to torrential, difficult-to-control venous bleeding from these thin-walled varices. It can turn a standard procedure into a nightmare.
That makes sense. Any other relevant tributaries?
We should also mention the veins of Sappi. These are small veins that normally drain parts of the diaphragm and the falciform ligament into the peripheral branches of the left portal vein on the liver surface. In portal hypertension, these can also enlarge and contribute to collateral flow, sometimes seen as prominent veins on the anterior abdominal wall around the umbilicus, Kempum Duce. Hashtag venous anatomy.
All right, we've covered the inflow, artery, and portal vein. Now let's look at the outflow system, hepatic veins.
All right, the drainage system. There are 3 major hepatic veins: the right hepatic vein, the middle hepatic vein, and the left hepatic vein. As we discussed with the Cuneau segments, these veins run between the portal segments within the main hepatic fissures. They collect the sinusoidal blood that has perfused the hepatocytes and drain it directly into the suprahepatic inferior vena cava, IVC, just below the diaphragm.
You mentioned a common variation where the middle and left veins join.
Yes, that's quite common. The middle hepatic vein and the left hepatic vein often merge just before entering the IVC, forming a short common trunk. Surgeons operating near the confluence of these veins need to be aware of this possibility to avoid injuring the drainage of a large territory.
Now let's revisit that key structural difference you highlighted earlier between hepatic veins and portal veins regarding their sheaths.
This is a critically important distinction, both anatomically and for intraoperative identification, especially with ultrasound. The portal vein branches, along with their accompanying hepatic artery branches and bile ducts, are enveloped within the liver parenchyma by a thick, fibrous sheath derived from Glisson's capsule, the Glissonian sheath. This sheath provides structural support. The hepatic veins, in stark contrast, run alone within the liver parenchyma and lack a substantial fibrous covering. They are essentially thin-walled vessels embedded directly in the liver tissue.
What are the implications of this difference?
Two main things. First, surgically, the lack of a sheath makes the hepatic veins much more fragile and prone to tearing during parenchymal dissection if not handled carefully. There's no protective layer. Second, for identification, this distance is a gift. On intraoperative ultrasound, the Glisonian sheath surrounding the portal triad structures is highly echogenic. It shows up as bright white. The hepatic veins, lacking this sheath, appear as thin-walled, anechoic, dark structures. This makes it relatively easy to differentiate between inflow portal and outflow hepatic vessels during surgery.
Very clear. We also need to mention the drainage of the caudate lobe again.
Yes, the short hepatic veins. Remember, segment 1, caudate, drains directly into the posterior aspect of the retrohepatic IVC via several small variable veins. These are entirely separate from the three main hepatic veins.
And controlling these is essential in certain procedures.
Absolutely essential. During mobilization of the liver off the IVC, for example, during major hepatectomies involving the caudate lobe, or during liver transplantation, especially using the piggyback technique where the recipient IVC is preserved. Each of these short veins needs to be individually identified, ligated, and divided to avoid potentially massive bleeding directly from the IVC wall.
Are there other significant variations in hepatic venous drainage?
Yes, although less common than arterial variants. Sometimes you can find a large inferior right hepatic vein, which drains the lower portions of the right lobe, like segment 6, directly into the IVC lower down, separate from the main right hepatic vein. Occasionally, large veins draining segment 6 or 7 might also enter the IVC independently. Again, preoperative imaging and intraoperative ultrasound are key to identifying these variations to prevent unexpected outflow obstruction or bleeding. #tag D. Other systems, lymphatics and innervation.
Let's briefly touch on the supporting systems, starting with lymphatic drainage. Where does the liver's lymph go?
The majority, about 80%, of the liver's lymphatic drainage follows the vascular structures internally. Lymph flows through portal lymphatic vessels that run alongside the hepatic veins or within the portoglisonian sheaths. This deep lymphatic system primarily drains towards two main groups of nodes: the lateral phrenic nodes near the diaphragm, and especially the nodes located in the porta hepatis along the hepatic artery, portal vein, and bile duct. The remaining 20% or so drains via superficial subcapsular lymphatic vessels.
Okay. And what about the nerve supply, the innervation? Does the liver need nerves to function?
It gets both sympathetic and parasympathetic nerves. The sympathetic supply comes mainly from the coeliac plexus, originating from the thoracic splanchnic nerves. The parasympathetic supply comes from the hepatic division of the anterior vagus nerve. These nerves travel with the blood vessels in the porta hepatis.
But we know a transplanted liver, which is obviously denervated, functions fine. So what's the role of this native innervation?
That's the interesting part. While extrinsic innervation isn't essential for the basic metabolic and synthetic functions of the liver, as transplantation proves, research shows it does play subtle but important roles. The native innervation appears to influence the fine-tuning of glucose and lipid metabolism, and there's evidence it also plays a role in modulating the complex process of liver regeneration after injury or resection.
Yeah.
So not vital for survival, but physiologically relevant.
Now let's integrate much of what we've discussed by looking at a specific anatomical concept used in Huerta surgery: the plate system. What exactly is this system?
The plate system refers to specific condensations of the fibrous connective tissue. Essentially, think in parts of the Glisonian system located strategically around the liver hilum and associated fissures. Think of them as fibrous scaffold organizing the entry and exit of structures.
The source material lists 4 main plates. Can you identify them and their locations?
Yes. The 4 key plates are: 1. The hilar plate. This is the main fibrous layer covering the structures within the central hilum, porta hepatis. 2. The cystic plate. As we discussed, this forms the bed of the gallbladder fossa, separating the gallbladder from the liver parenchyma proper. 3. The umbilical plate. This is the fibrous tissue lining the umbilical fissure, associated with the ligamentum teres and the umbilical portion of the left portal vein. 4. The aurantius plate. This is associated with the fissure for the ligamentum venosum posteriorly.
How does this plate system relate to the Glisonian sheaths that surround the vessels inside the liver?
The plates act as the interface, or gateway. The major vasculobiliary structures, portal vein branches, hepatic artery branches, bile ducts, pass through the hilar plate and the umbilical plate to gain entry into the liver parenchyma. As they penetrate these plates, they pick up their individual investments of fibrous connective tissue. That's the Glisonian sheath, which then accompanies them deep into the liver, branching along with the vessels and ducts.
What is the critical surgical significance of understanding, say, the hilar plate, especially in cancer surgery like hilar cholangiocarcinoma?
It's absolutely fundamental for achieving a safe and oncologically sound resection in cases like hilar cholangiocarcinoma, cancer arising at the confluence of the main bile ducts. The hilar bile ducts are intimately embedded within the fibrous tissue of the hilar plate. To remove the tumor with clear margins, an R0 resection, surgeon often needs to resect the bile duct confluence along with associated vessels and lymphatics. Knowing the anatomy of the hilar plate allows the surgeon to perform a meticulous dissection along the plane between the plate and the underlying liver parenchyma. Essentially, you carefully peel the hilar plate containing the diseased ducts and vessels off the surface of the liver segments, like segment 4 and 5. This technique, rather than just blindly cutting across the hilum, maximizes the chances of getting clear margins while preserving as much healthy liver tissue as possible and minimizing injury to the deeper structures. It requires intricate anatomical knowledge, #B, core procedures and hazards.
So, this detailed anatomy underpins a whole range of procedures mentioned in our source, from simple biopsies to the most complex operations.
Absolutely. The text covers the spectrum. Diagnostic procedures like percutaneous or transjugular liver biopsy, the entire range of formal hepatic resections, named according to the Brisbane 2000 terminology, things like left lateral sectionectomy, left hepatectomy, extended left hepatectomy, right posterior sectionectomy, right anterior sectionectomy, right hepatectomy, extended right hepatectomy, central or mesoaxial hepatectomy, and even smaller non-anatomical or segmental resections. And of course, the pinnacle of liver surgery, liver transplantation.
Given the variability we've hammered home, especially the vessels, knowledge alone isn't enough for mastery, is it? What tools are essential complements?
You absolutely need technological assistance. High-quality, multiphasic preoperative imaging is non-negotiable. That means contrast-enhanced CT scans, often with specific arterial, portal venous, and delayed phases, and sometimes MRI-MRCP, magnetic resonance cholangiopancreatography, to map out the individual patient's vascular and biliary anatomy, and crucially, to detect those 24–45% of arterial variants and any significant portal or hepatic venous variations before you operate. And then, intraoperatively, tools like ultrasound are indispensable for real-time confirmation of vascular anatomy, identifying tumor margins, and guiding the transection plane. Intraoperative cholangiography, injecting contrast into bile ducts, can also be vital for confirming biliary anatomy and ensuring completeness of resection or identifying injuries.
Okay. Before we apply this to a case, let's just quickly reiterate a couple of final safety points emphasized throughout.
Right. Remember the importance of systematically identifying and dividing the key ligamentous attachments for safe mobilization. The ligamentum venusum is often key for left-sided or hilar access, and the hepatocaval ligament needs careful assessment and division for mobilizing the right liver in IVC. And don't forget the utility of intermittent use of the Pringle maneuver, clamping the porta hepatis as a standard technique to control inflow and minimize blood loss during liver trauma, or the parenchymal transection phase of elective hepatectomy, ###C. Clinical case synthesis, ACC in segments 6 and 7.
All right, let's put it all together. Imagine a clinical scenario. A 56-year-old man is found to have hepatocellular carcinoma, HCC, a primary liver cancer located within segments 6 and 7. The multidisciplinary team decides the best treatment is surgical resection, specifically a right posterior sectionectomy. This procedure demands integrating virtually everything we've discussed. Let's break it down. First, define the territory being removed.
Segments 6 and 7 together constitute the right posterior section of the liver, according to the Brisbane 2000 terminology. Anatomically, this section lies posterior and somewhat medial to the plane of the right hepatic vein, the right viscera. It's a deep part of the liver.
Okay. What's the key surface landmark a surgeon would ideally look for to help locate the inflow pedicle specifically for this section?
The single most useful landmark, if present in 70–80% of cases, is the sulcus of Rouvier. Finding this cleft on the inferior surface of the right lobe gives the surgeon a direct guide to the location of the right posterior portal pedicle as it enters the parenchyma.
And controlling that pedicle before cutting the liver.
Makes the resection much safer and cleaner. It allows for ischemic demarcation of the section to be removed, and significantly reduces bleeding during the parenchymal transection by controlling both the portal venous and arterial inflow to just segments 6 and 7 beforehand.
Now for the mastery check. Before making the first cut for this right posterior sectionectomy, what are the 3 specific high-risk vascular variations that the surgical team absolutely must have ruled out or identified using the preoperative imaging?
Okay, 3 critical checks. First, the arterial check. The right posterior section is supplied by the posterior branch of the right hepatic artery. The surgeon must know if this artery, or the entire RHA, follows the classic pattern, or if it's an aberrant right hepatic artery arising from the superior mesenteric artery, SMA, that's the Hyatt type 3 variant, 10–15% risk. Missing this and injuring an SMA origin RHA during dissection near the hilum or pancreas would be disastrous.
Okay, that's check one. Rule out aberrant RHA from SMA. What's second?
Second, the portal check. While less common, they need to confirm the anatomy of the right posterior portal vein branch. Does it arise normally from the right portal vein? Or does it have an anomalous origin, perhaps coming off the left portal vein and crossing behind the hilum? Knowing this is crucial for planning the dissection around the portal bifurcation, they also need to check for a main portal vein trifurcation.
Makes sense. Portal supply confirmed. What's the third critical check?
Third, the outflow check. While the main venous drainage of the right posterior section is typically via the right hepatic vein, the surgeon must use imaging to look for any large aberrant hepatic veins draining segments 6 or 7 directly into the IVC, separate from the main RHV. These are sometimes called accessory inferior right hepatic veins.
Why is identifying those aberrant outflow veins so important?
Because if such a large vein exists and isn't identified beforehand, attempts to mobilize the posterior aspect of the right liver off the IVC during the resection could easily lead to tearing this vein at its junction with the IVC, causing massive, difficult-to-control hemorrhage from the vena cava itself. So mastery here isn't just knowing the standard anatomy, it's about systematically hunting for these specific known variations in inflow, arterial and portal, and outflow hepatic venous before you even enter the operating room. Hashtag tag outro.
So we've taken quite a journey today. From that initial small bulge on the fetal gut tube, the ventral foregut endoderm, all the way to mapping the complex, functionally segmented, and highly variable adult liver. We've really emphasized moving beyond those old, purely descriptive anatomical landmarks to embracing the functional surgical models, Kuno's segments, the Brisbane terminology that guide modern practice.
And I think if there's one core message for anyone striving for genuine mastery in liver surgery or anatomy, it's embracing structural humility. You simply cannot assume the classic anatomy is present. True competence, true safety, comes from obsessively anticipating that significant chance anywhere from a quarter to nearly half the time that you'll encounter a critical variation in the arteries or veins, especially those high-stakes ones involving the SMA or direct drainage into the IVC. You have to expect the unexpected.
Well put. Thank you for joining us on this very deep dive into the precision required to understand the liver surgical anatomy. It truly is an amazing, complex engine of life.
My pleasure. It's a fascinating organ.
And, as always, we like to leave you with a final provocative thought, something to mull over that builds on what we've discussed. We talked about the microscopic anatomy in Rappaport's zones, noting that Zone 3, the centrilobular region, is inherently the most susceptible to low oxygen and ischemic injury. Now, consider the future of cancer therapy. If companies are developing, say, targeted microparticle drug delivery systems designed to maximize therapeutic effect within a tumor, how might knowledge of these Rappaport zones be leveraged? Could treatments be designed to perhaps preferentially target cells in better oxygenated zones? Or conversely, could the known vulnerability of Zone 3 be exploited, or perhaps need to be protected, depending on the therapeutic strategy, to maximize tumor kill while minimizing damage to the surrounding, already metabolically stressed, low-oxygen parenchyma? Something complex to consider. Targeting treatment based not just on the tumor, but on the specific microvulnerabilities of the liver tissue surrounding it. We'll leave you with that thought.